Hi, I'm Dr. Andrea Abbott, a surgical oncologist at MUSC Hollings Cancer Center. One of my specialty areas is breast cancer, so I'm pleased to be able to host this episode of Hollings Crosstalk that focuses on breast cancer in honor of Breast Cancer Awareness Month. We're going to talk about some of the latest research happening here at Hollings with Dr. Peggi Angel, and we're going to talk to a patient, a lovely lady, Aleasa Barry. Peggi, Aleasa, thank you so much for being here with us today. Aleasa, I'd like to start with you. We know each other already.
Yes, we do.
I had the privilege of being your surgeon and meeting you when you were diagnosed with breast cancer. And then you got me to talk at a community health fair in Georgetown, which was a wonderful opportunity.
It was very, very good, very good.
And so because of that, I know you feel very strongly about getting the message out about breast cancer and educating the community. But maybe you could walk us through your story and how the breast cancer was discovered and what that process was like for you.
Well, this whole situation has completely changed me as a person. I got the phone call after having my mammogram done, and my primary doctor, called me Dr. Hood Watson, and I was at the office just about to leave my job, and she said, "Lisa, where are you?" And I told her where I was at. She said, "Well, I'll call you later." I said, "No, tell me now, because if you're calling me, I know there's something I need to know." And she said, "I'm sorry, but you do have cancer." And I'm like, "No." I said, "Okay, thank you." And I hung up the phone, and I walked out of the office. I didn't bother to tell anybody because I didn't know what to say. That had to sit with me first, because to me, no, this must be wrong. Maybe she's gonna call me tomorrow and say they made a mistake. I just did not think that I would have cancer. Why would I have cancer? Cancer doesn't run in my family. That was my thought. So I got over that initial thought. I didn't tell anybody, didn't tell a job, didn't tell my husband, didn't tell my family for a couple of days. Well, I had to tell them eventually because I had to have the biopsy. And I did tell my husband. Of course, I thought I was going to have to commit him to some mental institute because he could not, what is he going to do? What is he going to do if something happened to me? I said, well, I don't plan for nothing to happen to me, so I wouldn't go out and pick out my new wife. I plan to be here. I said, and I have thought about it. I want my doctor to do whatever she needs to do to keep me alive, whatever it may be, how long it might be. So then I went to have this biopsy. Had no idea what that was going to be like. I had no idea.
And you're talking about a biopsy by a radiologist or the surgery part?
No, I'm talking about the radiologist, when they started with let me go back. My mammogram was the first start. I did the mammogram, and when the lady pulled up the x-rays, I could see these two dark spots, and she quickly put it down because she saw me looking at it. But I still didn't think nothing of it. So when I did have cancer, I guess I was surprised, but I got adjusted to this. And then when they called me in and told me that, well, they're going to have to do the biopsy so they can get some tissues out and what have you. And I listened to them. I mean, that didn't sound like that was going to be that bad. Well, once I got there, it was something I was not expecting. I had no idea. I came and they told me that, you're going to wash yourself off, change the sheets, and did all of that. That was the easy part that morning. When I got into the room and I saw, lay back on the table, okay. And I saw these needles and these little cups and, everybody on the computers and what have you. And he said, the guy told me, he said, I'm going to go ahead and give you some deadening medicine so this will not hurt. Well, to today, I cannot figure out yet how they were able to get these tissues out because I don't remember seeing any scars on my body. But as he put them in, I could feel the pressure and what have you. So I asked the nurse who was in there, I said, do you have a mask to put across my eyes? I said, if I don't see him doing it, I don't think it's going to hurt as bad. She said, yep, your eyelids. Well, just from that remark, it sort of relaxed me. I thought it was funny. I thought she had a good sense of humor, and it tickled me. So at that point, I became relaxed, and they put the mask over, and over me. And I told them, I said, now y'all need to remember this. This might, if medical, you pick up this practice, make sure you call it Aleasa Law, okay? Because it did help me. I was no longer nervous. Well, we got the biopsy. I remember the pain was bad at one time, and I remember somebody grabbing my hands, and they held my hand. I didn't know who it was because this was hurting, but I knew I wasn't gonna, this is something I had to do, and I had already, said in my mind, I'm gonna do whatever I need to do that's gonna help me to continue to live. And when I look up, it was Dr. Abbott, and she just smiled at me, and she left. I didn't see her no more. I don't remember where she went or what, but she held my hand and we got through it all, and that was that.
So I think you bring up a couple of good points, and so I want to just kind of highlight them. I think for a majority of women, they go in to get their screening mammogram, not expecting to get the call back, right? Like, this is just something that we do. This is part of our health maintenance. And so the jarring phone call of something's not right, you have to come in. And then you go in and you don't know what to expect for this biopsy that's going to happen. And so what would you tell patients to kind of help them prepare for the biopsy? Is there anything they can do?
Well, what they can do, for one, is think positive. And that was what I tried to gear myself about. With every step, I tried to think positive. I think another thing is to relax. Relax yourself, relax your mind, and understand that this is something that you have to have done in order to get better. Other than that, I don't really know what else to say, what else you can do, because everybody's going to react differently. I think if I had known what to expect, I'm not sure that it would have helped me. I don't know if I would have been more nervous or just to have gone in there and just did what I did. It was not a bad situation for me. I was happy when it was over with, but it wasn't a life-threatening thing. I was able to live with it. The guy that did mine, he was very good. I felt very little pain, or I had already blocked my mind that I was not going to feel pain. And I think you have to get prepared. That person has to prepare themselves for what they need to do. And if you prepare yourself, I think, in a positive manner, I think you will get very positive results. And I think that's what I got, and that's what I did.
So you went through the biopsy process, and then you said Dr. Hood-Watson called you and said, Miss Barry, I'm sorry, your results came back and it was cancer. And then at that point, maybe some denial that this wasn't true, this wasn't happening to you.
I didn't think it was. I didn't think it was happening, but I didn't think my doctor was calling me and telling me that she had made a mistake. I really didn't know what to think because, like I said, cancer does not run in my family. Why do I have cancer? I have 2 other sisters; they don't have it. So I just had to accept that this is what was happening, and I had to accept whatever treatments they told me that I was going to have, because my main concern is that I wanted to continue to live. I wanted to continue to be helpful. I just wanted to be here. So whatever it took, I was prepared to go through. I was prepared to endure, but I wanted to live, and thank God I am here to live, that I am living.
So shortly after that, that's when you and I met, I suppose.
Yes, we did. Yes, we did. I was going into surgery.
Well, let's talk about the multidisciplinary clinic experience, right? So you came to Hollings, and that day you probably met me, a medical oncologist. Yes. What was that experience like? Talk to us about what the clinic setup was like.
The clinic setup was excellent. And I even told you, for such a serious illness, each person that I came in contact with, once I hit Hollings Cancer Center, made me comfortable, from the lady that checked me in, to the nurses, to just everybody I came in contact with. They were just so friendly and just made you feel so comfortable. And I was so happy, because once you get in the back, you're by yourself. You're among a bunch of strangers. There's nobody else, there. But I felt comfortable. I was, you know, I was fine. Um, and then the day of the surgery, I had no idea what they were going to do, except that I would be asleep. And one of the guys came in and he said, "Miss Mack, and you have to look down in case they had to put the tube down." I opened my mouth, and then of course I have these veins that's really hard to find. We finally found the vein that got the IV in, and he told me, he said, "Your surgeon is going to come in soon." So I looked up, and this tall, slim lady came in with a very soft-spoken voice, and I'm saying to myself, I wish she'd speak a little louder. And she said, "I'm Dr. Abbott. I'm going to be your surgeon." But the smile she gave me, and she grabbed my hand, and she said, "You're going to be okay." That was all I needed. I was fine. And I even told her, "Did I tell you that day?" I said, "God, you got the best team." And you said, "I think so too." I said, "Everybody just make you feel comfortable here, and I really appreciate that." And I don't remember anything else because the next thing was I was awake and in recovery.
Yeah. The thing I really like about the team is for all of our new breast cancer patients, the day that I meet you, we've reviewed all of your imaging and your pathology, and we've met as a group, medical oncology, radiation, surgery, to talk about, what are the guidelines and recommendations. And then I get to meet with the patients and give you that information, and we have a conversation about what is it that you would like, what is the best treatment, and where can we meet in the middle.
Well, my best treatment is, if you can remember, I told you my treatment was that I wanted to live. And I told you, if you remember, do whatever you need to do. Don't wake me up. If you got in and you needed to remove the whole breast, feel free to do so. I just want to wake up and be alive. I was not worried about the cosmetic. I said, well, I can get some new ones if necessary. At my age, I probably don't even need them.
Well,
but I woke up and I was alive, and that. To me, you had done an excellent job. That's what I asked for. That's what I got.
Well, I appreciate that. Thankfully, in your case, we were definitely able to catch it a little bit earlier. And so hopefully you've been able to avoid some of the more aggressive, treatments like chemotherapy. And I think that dovetails nicely. Peggy, thank you for being here with us today. Tell us about the research, that you're doing. We know that unfortunately, white women in South Carolina are more likely to be diagnosed with breast cancer than Black women. However, unfortunately, once they're diagnosed, we know Black women tend to die at higher rates than white women. And so we would consider that a health disparity. And that's really something we want to focus on here at Hollings, from the medical side, how we improve screening, and how we get research and access out to our patients. So tell me about your research and any health disparities you're uncovering.
Sure. So first I want to say it's such a pleasure to be here with you, Dr. Abbott and Lisa. It's wonderful hearing your story.
I appreciate it.
So I'm very passionate about cancer disparities, particularly breast cancer. So as Dr. Abbott was mentioning, the incidence for white women and Black women are the same, but the mortality is higher in Black women, and that's because they have more aggressive breast cancers. The question is why? Nobody knows this. Well, one of the things that my laboratory looks at are a type of proteins called collagen proteins. And these proteins have been shown in many breast cancers to predict progression as well as outcome, meaning they can predict whether a patient's going to survive longer or not. And so my lab looks at the protein structures and how those change, and that research is done on human tissues. So these are tissues that are collected here at the Hollings Cancer Center through kind donations from patients.
Thank you.
So that really drives the research. So we're looking at both very aggressive breast cancers and comparing those by ancestry. We have an excellent network here at MUSC and Hollings Cancer Center that includes Marvella Ford, as well as a broad national network of researchers focused on disparities. We're also looking at the normal breast tissue microenvironment. So we want to understand risk. So does this risk start early in life, and is it dependent on ancestry?
So let's talk maybe specifically about the Sea Island population, and then just to be clear, that's the Gullah Geechee who have descended from the enslaved people. For many generations, they remained on the Sea Islands of South Carolina in isolated communities. So what have you found from studying this population?
So this is a very special population. They have very strong ties still to the West African coast, which we know is linked to higher breast cancer risk and also more aggressive breast cancers. And so working with Marvella Ford, we were able to put together a study that looked at women in the Sea Islander region by ancestry. And so one of the things that we found that is really driving new research is that it might not only be the breast tissue microenvironment, but it might also be our immune system that allows this aggressive breast cancer to spread, which is directly related to mortality.
So if we kind of think about that, and then you had done some research on collagen, I believe, as well. Are there some clinical applications or things that we can take from your research now to help patients like Aleasa?
Yeah, absolutely. So the technology we developed here at MUSC specifically for cancer and breast cancer research, we're expanding that to go down and look at breast cancer risk. And so all of our research is directed not just by the patient needs, like here is a high-risk population, but also by the surgeon's needs. So we look at molecular patterns. We also look at changes in serum related to risk and progression. So it will become we're hoping it'll become a non-invasive biopsy so that patients don't have to deal with that, the challenges of going through a biopsy. So one of the things that I wanted to know is, what are the directions in surgery that could be helpful for patients?
Yeah, I think that's what we're all trying to do, right? Is figure out how to be less invasive and get patients back to their lives faster. So, from the era of having to do, at least as you put it, removing the whole breast, to save someone's life, we're now finding you can remove, maybe just the area of cancer, and with some additional targeted treatments, your survival is just as long as the person who had a very, radical operation. And so, as you've said, tailoring those treatments. Obviously, some people will present, with more advanced cancers and will need that larger surgery, but that's not every person. So from a surgical perspective, we're trying to hide scars. So finding, ways to do a cosmetic surgery so that when you look in the mirror, maybe you don't recognize anymore that you had to go through that you had that surgery. It's not a constant reminder. From our medical oncology colleagues, trying to find ways to use immunotherapy, which is different than traditional chemotherapy, different side effects, maybe tolerated a little bit better, boosting a patient's own immune system to fight the cancer. And then plastic surgery has come a very long way in how we're able to do breast reconstruction, providing the sensation and maintaining that cosmetic look so that a woman, looks and feels like herself. Speaking to tailoring the treatments down, it really lends us to that conversation about screening and how do you detect the cancers early enough so that, people have a lot of options. Trying to see how can we get access to where people are. And you're, Aleasa, about to start radiation, right?
Right. I start on the 19th, as a matter of fact.
And
This month.
Yeah, and so the radiation for you is part of your treatment because you're able to maybe have a less invasive surgery, right?
Right, that's exactly right. And
Right.
that's what I want to do.
And so, speaking to screening, here at MUSC, we're starting to offer screening mammograms in West Ashley. So trying to expand our access. So for the patients out in West Ashley, James Island, Johns Island, even parts of North Charleston, you can go to the Citadel Mall where there's plenty of free parking. It's a nice large facility, and we're hoping that by next year we'll be able to do more breast services there, potentially even biopsies. So at this point in time, our screening is downtown, Mount Pleasant, and out in West Ashley. And then just to kind of go over what that screening looks like for the average woman, it's starting at age 40. Of course, that's different if you have a strong family history. Maybe you need to start a little bit earlier. And that's really a discussion to have with maybe your primary care physician. So, getting back to you, Peggy, what is your vision of where you think breast cancer research is going? What do you think the advances are that are coming?
So I would tie that back to our continued work. It's really very much dependent on the patients and the surgeons. So we need donations from the patients so that we can understand the molecular patterns in the breast microenvironment. And so we can develop more non-invasive assays that can maybe say, hey, you're actually at high risk for breast cancer. You might need more screenings at a younger age. And we think that that can help people. And then on the surgery side, our clinical questions are really directed by the surgeon and trying to understand, how changes, particularly in collagen, can help the surgeon maybe select the right tumor margins is one case, identify more aggressive breast cancers is another. So maybe it might be stage 1, but it looks like it's matching the patterns of a more aggressive breast cancer. So you might want to look at it a little more closely. So we like to work hand in hand with both the patients and the surgeons.
That's great. I love that idea. As a research institution, part of the consent process is asking, at the time of surgery, if patients are willing to donate tissue. And, just to clarify what that means is I'm taking that tissue out to get rid of the cancer, and that's already being, taken from the patient as part of the intention to treat and cure. So we're not asking for additional tissue. It's part of that tumor that's already been removed.
And in our research, we really work to have research processes that can identify cancer that go hand in hand with the oncologist and the pathologist. And it's a tissue sparing process. So whatever the pathologist does, we actually look at the same exact tissue. So there is no extra pain and trauma for the patient. That's a strong point for us.
Yeah, absolutely. You shared so much about your experience, Ms. Barry. Is there anything else that you want people to know?
Well, what I'd like to say, if you have not had your mammogram, I think everyone should take this very seriously. And since it only takes anywhere from 15 to 20 minutes, it's not taking too much of your time, but it might be giving you more time if there is a problem. I say this to everybody that might be watching this, and I've told all of my friends the same thing. This 15-minute test can give you a longer life than not having it done at all. And you can live through it if you catch it early enough.
What a great, important message.
Thank you.
Really appreciate your time here with us today. Dr. Angel, thank you very much. This wraps up this episode of Hollings Crosstalk. We hope you've enjoyed it. Just remember, it's so critically important to get your screenings and to remind your loved ones to do the same. I can say firsthand, it's much easier to treat the earlier we catch breast cancer. If this is your first time watching, make sure you go to our multimedia page to watch past episodes and check out the Hollings News page for our latest updates. Thanks again for tuning in to Hollings Crosstalk, where we connect with the community to share news that's changing what's possible.